Hello, good evening, everyone, and welcome to our 365 Live. So, 365 Live is a platform where we educate our public on cancer and encourage a cancer prevention lifestyle. So, whenever you see this logo 365 Live, you will know that 365 Cancer Prevention Society is currently having a live broadcast. So, my name is Hui Xin, and I'll be the host for tonight's live session. So tonight we'll talk about risk of recurrence in HER2 positive breast cancer, and you will learn about the causes and the risk factors of the breast cancers. So this talk is specially brought to you by 365 Cancer Prevention Society and our esteemed medical partner, Specialized Therapeutics Asia Private and Limited. So let's give a very brief introduction about 365 Cancer Prevention Society. So 365 Cancer Prevention Society, as also known as 365 CPS, was founded in 2003 as a social service agency with IPC status, and we are a full-fledged member of the NCSS. The society's mission is to serve the community through our holistic cancer prevention measures. And this is accomplished through our community and health talks and education, promotion of healthy lifestyle, and our lymphatic detox exercises. So we also provide practical and emotional support and care for our members and their family members as well in the battle against the cancer through our residential and also hospital visitations, some counseling sessions, nutrition and dietetics consultation, and some wellness services. So please like, share, and comment on all our social media page for the latest updates on our events and activities. So before we begin our today's talk, I would like to introduce you a campaign brought by 365 Cancer Prevention Society. So the campaign is named Are You at Risk? So as you may know, lung cancer is one of the most common cancers in Singapore. And hence, 365 CPS has launched Are You at Risk campaign. So to raise funds for individuals aged 50 to 80-year-old who have smoked or are currently smoking and they are from the low income backgrounds so that they can attend a sponsored low dose CT scan to rule out the risk of lung cancer. So this screening will allow for early detection of the lung cancer and early treatment as well. So if you know anyone who may meet the following criteria, so do take a photo of the slides. So the age 50 to 80 years old and currently smoking or has smoked and they are from the low income backgrounds. So you may register with us by emailing to our colleague, our staff, Eileen at this email address, as you can see on the screen, or contact any of our community partners in our next slide. So in the coming slide, you can see that here are our community partners. So do spare a minute to take a photo of this slide as well if you find it's necessary. So remember, early detection saves lives. So the simple act of sharing may go a long way to help a dear friend, neighbor, or even our family members. And not to forget, a special thank you to all our partners for making this lung cancer screening possible. So before we start the talk, please kindly note that all the information shared at this event or any of the talks by the speaker and 365 Cancer Prevention Society are only for general information purpose and they are subjected to changes. So do consult your individual doctor for personalized and detailed medical advice. Thank you. So now I would like to introduce everyone our tonight's speaker. So Dr. C. Dr. C is a senior consultant medical oncologist from Parkway Cancer Center. She specializes in adult breast and gynecologic cancers. So without further ado, let us welcome Dr. C.
Thank you very much, Hui Xing, for the kind introduction. It's a pleasure for me to spend Saturday night with all the audience here on Facebook. And I'm sure that, in fact, the timing is perfect because it would have been after the NDP fireworks. So without further ado, I'm just going to spend the next 20 minutes or so going through some general guidelines about how to prevent breast cancer with a specific attention paid on HER2 overexpressed breast cancer. So I've named this breast cancer, know it and beat it, because to specify just on HER2 overexpressed breast cancer, I think we will not focus, we will not be able to satisfy some of the curiosity of our audience today. So it's important to know some of the strategies for general breast cancer prevention. So first of all, some of us may not know that carcinogenesis, which is the happening of cancer, that how cancer develops, takes many steps. So some people may ask, oh, do I have the genes for it? If I have a genetic mutation, does that mean I'll definitely get cancer? Generally speaking, there is this concept called the two-hit concept, meaning that if we have a genetic predisposition, we still need to have a second hit of perhaps inflammation or carcinogens, exposure to carcinogens before one can get cancer. Similarly, having been exposed to one carcinogen doesn't mean that one would definitely get cancer. That's how people who smoke almost, not everyone can get cancer. But of course, there are also people who do not smoke and get cancer. There are also individuals who are not genetically have a genetic mutation and can get breast cancer. And then there are other ladies with genetic mutation who don't get breast cancer. So sometimes it takes 3 or 4 hits. So carcinogenesis can happen over many, many, many years. Hence, it takes many years also for us to prevent breast cancer. The earlier we know, the better it is. And I like the concept of 365 prevention, because 365 prevention clearly means every single day, for 365 days, we're thinking about cancer prevention. So here is just to share some of the carcinogens that we are aware of. For example, ionizing radiation. If I work in an X-ray department and I don't protect myself and I don't measure the amount of radiation that I get on a daily basis, then I might be at risk. Clearly, smoking can, pollution can, infection can. But there's one word to mention in all this, and that word is called inflammation. Inflammation results in repair of cells, and the over repair and the over dying of cells results in cancer. So, over the years, if we can reduce inflammation, we can actually actively reduce cancer. So the risk factors for breast cancer includes age, family history, genetic mutation, and obesity. All this age-wise, as we age, our ability to repair, our risk at inflammatory conditions, our inability to escape carcinogens, the onset of carcinogens, and the how carcinogens affect our body. Family history means we already have one predisposition, and of course, obesity itself is a great trigger for inflammation. All this is at increases the chance of breast cancer. So to know breast cancer, to prevent it, is to know its symptoms and diagnosis. So breast cancer screening permits early detection. Early detection means that we have to find the cancer below 2 centimeters. Sometimes that's impossible to find by feeling the breast. We have to go for regular mammograms. By regular, we mean every 2 years for ladies above 60 years old, every year above 40 years old, go for mammograms and plus minus breast ultrasounds or even breast MRIs. For ladies with no symptoms of breast lumps, no symptoms of nipple discharge, no symptoms of any pain, they go to see the doctor and say, I'd like to check to see if I have any early breast cancer. If a person already have a breast lump or nipple discharge, that's no longer a screening. It is a diagnosis. So breast cancer screening permits early detection so that we can find a tumor as small as possible, hopefully at stage 1, so that we can give the best chance of cure. The staging of the breast cancer is a combination of the size of the tumor, the number of lymph nodes that are involved, and whether the cancer has spread to the other parts of the body. If the person is suffering from cancer that has already spread to other parts of the body, like the bones or the liver, that we already call it a stage 4. For cancer to be stage 0, we call it ductal carcinoma in situ. In situ means this type of tumor cannot spread. It doesn't have the ability of spreading. That's why we call it stage 0 or DCIS. Most cancers and breast would start off with DCIS, and the best way of detecting DCIS is through mammogram. Stage 1 breast cancer does not involve the lymph nodes. Stage 2 involves a few lymph nodes or no lymph nodes but a larger size of the tumor. Stage 3 being many lymph nodes and larger size of the tumor. And of course, advanced breast cancer, by advanced, we mean spreading of the breast cancer to the lung, to the bone, to the liver, to the brain. This we consider as stage 4. It's not true that stage 4 is not curable, By the word cure, we means that the patients go on to survive for more than 10, 20 years and then eventually pass away from another condition other than the breast cancer. But the chances of this so-called cure or long-term survival is less than 5% for some cancers, can be as high as 30% for some cancers. But for very slow-growing cancers, patients eventually pass on from breast cancer even at 30 to 40 years later. So once the cancer has spread beyond the primary organ, the chances of cure will be very, very difficult, but it is not impossible. The staging procedure requires, first of all, of course, as commonly as a biopsy, meaning we do need to confirm that it is a cancer. A breast tumor may feel painful, a breast tumor may feel like a cancer, but it isn't cancer until we can prove that it is one. We then need to generate the pathology report to find out what type of cancer it is, and then we do imaging to look for the spread. Bone scan, chest x-ray, ultrasound liver, CT scans, or PET CTs to see if the cancer has already spread. This can be simple imaging or very complex imaging based on how fast the cancer is growing and how occult we think the breast cancer has spread. The histological subtypes and prognosis. This is important to share because HER2 overexpressed breast cancer used to be considered and is still considered as one of the more aggressive breast cancer. Fortunately, because of advances in medical care, we now have many, many treatments that are available to cure this type of breast cancer. So histological subtypes include invasive ductal, medullary, invasive lobular, mucinous, tubular, papillary, and infiltrative ductal, and others. In terms of medullary, mucinous, tubular, and papillary, these, as you can see, is rare. They are rare, but they are very, very, very good in prognosis. Despite being a cancer, patients go on to survive more than 90% with simply surgery alone without the need for chemotherapy or even sometimes even medications. However, invasive ductal, infiltrative ductal tend to be more aggressive. And we classify them now because it's a heterogeneous disease. We classify them into still low grade and higher grade. We classify the estrogen receptor positive breast cancer as luminal A, which is very slow growing, to luminal B, which is slightly more aggressive and sensitive to chemotherapy, and the basal-like or triple negative, and the HER2 overexpressed breast cancer, which is the topic of our interest today. Just to share a little bit about luminal A breast cancer. Luminal A breast cancer is estrogen receptor and progesterone receptor positive, meaning it is sensitive to the female hormone, but it can still occur in both pre and postmenopausal ladies. It is HER2 negative, low grade, and has the lowest chance of recurrence. And again, these are usually mammogram detected because it takes years for it to develop. It is associated with obesity, older age, and sometimes hormone replacement therapy. If found early, all we need to have is surgery followed by medication. We now know whether the cancer is luminal A or faster growing and requiring chemotherapy by using genetic analysis of the tumor. This does not tell us if the patient is predisposed to cancer, but it tells us whether the cancer is sensitive to chemotherapy or not. If it isn't sensitive and it's low grade, then patients do not need to have chemotherapy. This is just a graphic interpretation, a graphic illustration of how the last 100 years have been in terms of understanding breast cancer, all the way from 1896, where Dr. Beardson did a first surgery for breast cancer recurrence by removing the ovaries. By removing the ovaries, we found that breast cancer is associated with hormones. Luminal B tends to be a estrogen receptor positive, progesterone receptor positive, HER2 negative, but higher grade. Higher chances of recurrence and mammogram detected or lump felt, and it's associated with young age, family history, and this require both chemotherapy and oral medication. So we come to the more important part now, which is the HER2 overexpressed breast cancer or triple negative. We know that all cancers, even the HER2 overexpressed, requires the staging to tell us how well the patient is going to do. Chemotherapy will benefit everyone with HER2 overexpressed breast cancer. This is again a slide regarding new targeted therapy for the ER positive, but not relevant to HER2. This is very relevant to HER2 overexpressed breast cancer. Long ago, perhaps about 10, 20 years ago, we used to just do surgery followed by chemotherapy. Patients used to go through very extensive surgery followed by toxic chemotherapy. And then we said, okay, let's just now wait and see whether the chemotherapy will improve the chance of cure. But nowadays, we prefer to give the chemotherapy upfront, what we call neoadjuvant chemotherapy, to see the cancer shrinking in front of our eyes so that we can tell who are the ones who may have a higher chance of recurrence, who are the ones who are going to have a lower chance of recurrence. Clearly, by common sense, if the cancer completely disappears with the primary chemotherapy that we give, we know that this patient is going to go on and experience a long term survival. If they do not have a complete response, we need to then change the therapy before we can tell the patient they may have a chance of a long term survival. In the past, if surgery is done first, followed by chemotherapy, we would not be able to fine tune the treatment like this. Now we give the chemotherapy first, we find out if there is any residual cancer, and then we go on to offer second line or even third line treatment in order to eliminate the cancer and reduce the risk of recurrence. So, this brings me to the HER2 overexpressed breast cancer. While I say that it's 15 to 30% of all breast cancer, we're actually seeing it on the increase. The ER can be positive or negative, and the progesterone receptor can be positive or negative, but all of these cancers are HER2 overexpressed, strongly overexpressed, associated with younger age, and because it is more aggressive and it grows faster, it is associated with a lump. It is rarely found by mammogram screening. So that brings me back to the importance of breast self examination every single month. Even if a mammogram was normal and there was a breast lump felt, a patient needs to go for a second opinion. All patients require to have chemotherapy or a discussion about chemotherapy with targeted therapy such as Herceptin or Perjeta to reduce the risk of recurrence. So this is historical timeline for chemotherapy and targeted therapy for HER2 expressed advanced breast cancer. In 1955, we only had chemotherapy. In 1975, we still only had chemotherapy. In 1995, we still only had chemotherapy. So over 30 to 40 years, we only had chemotherapy. In fact, we didn't know anything about the HER2 overexpression. It was in 1995 then that the receptor HER2, or standing for human epidermal receptor 2, was found and a targeted therapy was developed, and it was first approved in 1995 for the treatment of advanced breast cancer. Following that, we've had multiple numbers of targeted therapy, Herceptin or trastuzumab, lapatinib or Tykerb, ixababilone, eribulin, Perjeta, TDM1, neratinib, tucatinib, and pen-HER2 now, and HER2, and more HER2 overexpressed target therapy are being available. So we now use these new targeted therapies in curative setting. What does it mean? We mean by giving the standard of care Herceptin-based chemotherapy. If we see that this is a patient with a curable cancer and not an advanced cancer, and after the standard first-line chemotherapy, there's still residual cancer, we go on to give them the second line. So if there is no other take-home message for what the doctors can do, a patient would need to discuss carefully with the doctors as to what chemotherapy is suitable for reducing the risk of HER2 overexpressed breast cancer. HER2 overexpressed breast cancer is not the type of breast cancer that we can go and do natural healing. Other cancers may be, a low grade cancer maybe, but a HER2 overexpressed breast cancer represents a cancer where a receptor is broken. There is nothing natural that can help to cure this cancer. There is nothing natural that can help. We can only rely on chemotherapy, and then after that can heal back the body by using natural means. I'm just going to share a little bit more because people may ask this question: what about the HER2 negative, triple negative breast cancer? This is equally high grade, and there are other treatments that are available, including checkpoint inhibitors and immunotherapy, to try and cure these cancers. But this is not our topic for today. Triple negative breast cancer, again, just one mention, is that it may be associated and mostly associated with the BRCA gene, or what we consider as the Angelina Jolie gene, where patients with this mutation carriage can have a higher chance of a triple negative breast cancer. So, targeted therapy, as I mentioned, in the triple negative breast cancer includes immuno checkpoints and BRCA mutation targets. So, what about advanced breast cancer? How do we improve advanced breast cancer quality of life by using targeted therapies? We must pay attention to the side effects and the life expectancy. Many patients would like to know, of course, how do I reduce my risk of breast cancer recurrence after chemotherapy if I have HER2 overexpressed breast cancer? And I hear that the chemotherapy can really give a lot of side effects. Can I take supplements to reduce these side effects so that I can survive and tolerate the chemotherapy much better? So we have a lot of patients who try and go on supplements, medications, TCM, which I don't disagree with, but it must be used very carefully and judiciously in minimizing toxicities. Many studies have actually shown that it is a myth that supplements can reduce toxicity. In fact, by reducing the toxicities of chemotherapy, dietary supplements can actually reduce the chance of cure from breast cancer because it prevents the chemotherapy from doing what it's supposed to do. It can reduce short term toxicities but affect the long term cure because the chemotherapy needs to kill the cancer cells, and the cancer cells belong to us. So, in order to protect our own cells, we ultimately inadvertently protect the cancer cells against the damage by the chemotherapy. But because the cancer cells are faster growing, they are more fragile, they will die faster, whereas our normal cells are more resilient and they will recover eventually. So the reality is that doctors really have a lot of supportive therapy that can already reduce the side effects. So talk to your doctors, talk to the doctors about the risk of side effects and see if there are good medicines that we can use without going into supplements, which can also protect the cancer cells. What about other ways of reducing cancer recurrence and natural ways of reducing chemotoxicities? We know that excessive nutrition or obesity can trigger inflammation. That's very well documented now. So, chemotherapy causes inflammation. Therefore, side effects of chemotherapy can be reduced by reducing inflammation, by reducing obesity. So, all patients may want to embark on a good nutritional plan that can help them to focus on nutrition and to reduce unnecessary calories that results in obesity. A balance of nutrition and survival. This is a very raw score where we look at body mass index and survival. In patients who have a higher body mass index, their survival is less. If they have a lower or a normal body mass index, their survival is higher. Despite that, even if a person has a higher um, body mass index or a BMI, if they are physically active, they can increase the chances of cure after diagnosis. So let's look at breast cancer and lifestyle. The link between animal protein and breast cancer. Many patients with HER2 overexpressed breast cancer would ask me, can I still eat meat? Meat is actually the best source of animal protein. It's better than fish. It is the most complete and it can heal a person from chemotherapy the best. So, meat itself is not the culprit. It is how much we take and how we cook it. If we take more than 1 gram per kilo of meat, not other plant based protein, of meat, and we barbecue it, then that's not good because that has been associated with increased risk of not just breast cancer but also colorectal cancer. But meat itself is not the culprit, it's how we cook it and whether we eat too much of it. So, how much is too much? Well, we can eat more than 100 grams. Well, we can eat about 100 grams to 200 grams of red meat a week, and that would be very safe. The rest has to be fish. What about sugar? By having excessive amounts of sugar that we do not use, that will trigger a high insulin response and trigger the insulin receptor and promote the possibility of cell growth, including cancer. And this is again mitigated through inflammation. So, the connection between sugar and breast cancer in all types of breast cancer, this was a French study done some time ago now, where they looked at if a person drinks more than 100 mils of sugary drinks, including fruit juice, can increase the risk of breast cancer by 22% and death by cancer by 18%. Mind you, this is not a study looking at eating low sugary fruits like the berries, blackberries, blueberries, red berries, strawberries, raspberries. These are berries are high in antioxidants and very low in sugar. But because of that, they don't taste very nice like our Asian fruits such as durian, mangoes, apples, pears. They are very, very sweet. So in a way, we do not drink sweet drinks. We also do not drink fruit juice because this is pure fructose. It's better to eat the fruit and it's better to stick to low sugar fruits. So the metabolic syndrome and breast cancer, again, we mentioned that the higher the weight, the higher the BMI, the higher the risk of cancer recurrence and occurrence. Hence, it's recommended that, again, 365 cancer prevention, 365 days of the year we need to keep our weight low within the healthy range, not low as in below the healthy range. So being thin and anorexic is not the way to go. We need to keep a normal, healthy range weight. Be physically active for more than 30 days every day, for 30 minutes every day, and sit less. Avoid high calorie food and sugary drinks. Eat more grains, vegetables, fruit, low sugar fruits and beans, and limit the intake of red meat, less than 500 grams a week, and avoid processed meat altogether. And do not drink alcohol. So the biological function of white adipose tissue, remember that as we age, as a woman ages, we hold on to fat more because of our hormones. Therefore, that in itself can become a very active organ that promotes inflammation, angiogenesis, can increase blood pressure, can reduce our immune system. So all that is harmful and it can increase cancer. What about xenobiotics and endocrine disruptors? So again, patients will ask, well, I have HER2 overexpressed breast cancer. Can I still use plastic? Can I still use cosmetics? Well, there are certain compounds in the cosmetics and plastics such as BPA, parabens, which have been found to be associated with breast cancer, and hence it's better to use paraben-free and BPA-free plastics. What about other studies such as soya, dietary, phytoestrogen? Can I have soya bean because I have an ER positive, PR positive, and a HER2 overexpressed breast cancer? Interestingly, we look at the Danish studies, we look at the USA study, there are really no increase in recurrence risk by taking soya products. So it's not true that if we were to take soya products, that would affect our chances of cure, especially especially in Chinese studies. Soya intake and breast cancer survival actually has a reverse. The higher soya product we take, the lower the risk of breast cancer death. So why is it that in the Western country we show that there is no difference, and in the Chinese and the Asian studies it shows a decrease? Very simply put, it is to do with the way that we eat the soya. One can say it's GMO, but one can also say that when a Western country eats soya products, they ultimately drink a lot of soya milk, which is processed, whereas we eat tofu, which is less processed. So it is okay to eat tofu, but it is not okay to drink soya milk day in, day out, day in, day out. So this is a large study, a meta-analysis, which is the collection of many, many number of cases, and the soya intake and breast cancer. It all shows a reduction in breast cancer risk by taking soya products. How do we reduce breast cancer otherwise? We can have soya products, we can lower our BMI, we can have carotenoids, natural food, vegetables, higher healthy eating index score, meaning focusing on nutrition and less on unnecessary calories. Interestingly, we put here literacy. That means the more knowledge a person has, the higher chance of cure. Why? Because people who have more knowledge will seek more knowledge. So, this is why you are attending this talk right now. So, to be physically active, optimal dietary strategy to decrease serum glucose, insulin, increase HDL, which is the good cholesterol, all this, and as well as physical activity, can decrease the risk of breast cancer, occurrence, and recurrence. Dietary protein sources in early adults. Higher fish consumption is inversely associated with risk. A meta-analysis of 10 prospective studies also show an inverse association between dietary fiber and the risk of breast cancer. Generally, this is true for all breast cancer, not just HER2 overexpression of breast cancer. There are some other studies that look at borderline results. Cruciferous vegetables, there are some protective studies, cruciferous vegetable being broccoli, cauliflower, cabbage, all this reduces the amount of estrogen, both exogenous, that means taken from my mouth, or endogenous, which is produced by my fat. It reduces the function of that in the breast, as well as reducing the harm it can do to the breast tissue. So, by exercising, again, we stress adequate exercises, but not over exercising. Too much exercising is bad, too little exercise is bad. We should do no more than 7 hours a week of exercise, unless you're a training athlete. So, to focus on the fruit and diet is what we can do at home, but at the clinic, it's important to discuss with the doctor, what is my stage? What treatment do I need? Do I need chemotherapy before or after the surgery? Do I need targeted therapy? How much targeted therapy do I need? So on and so forth. And how to follow up breast cancer after we've got it. The frequency and duration of follow up. For HER2 overexpressed breast cancer, we tend to follow patients a little bit more closely because of a slightly increased risk of cancer recurrence. However, this is based in the first 4 years. If the breast cancer does not come back in the first 4 years, and we know that by intensive blood test, tumor marker, chest x-ray, a clinical assessment, discussing with the patient their symptoms, if it doesn't happen in 4 years post-surgery, it practically isn't really going to happen anymore. And we do find that in this follow up period, it is also important to teach our patients how to de stress. In my own personal opinion, HER2 overexpressed breast cancer, for some reason, occurs in people who are extremely anxious about every little thing. They tend to be perfectionists, they tend to have a specific way of doing things, and they can't be flexible. So during this follow up period, I usually focus a lot of the time on teaching a person how to learn how to relax and to change their mindset and their mentality. This is actually a guideline that was published last year. Not much changes this year. As to the components of monitoring, they largely discourage regular scanning because by doing regular scannings, we accumulate radiation, sometimes a little bit too much. But there is definition of disease progression. Patients need to look out for worsening symptoms such as pain, shortness of breath, and new lumps and bumps, fatigue, unexplained weight loss, feeling tired, constipated, just new symptoms. These we encourage patients to see their doctors before the actual appointment. But of course, we must also be aware that we must support each other in the office and at home. Women with breast cancer with accommodating employers are more likely to retain their jobs after treatment. You know, there are a lot of people who think that individuals who get breast cancer can no longer work. But here I have a cartoon showing how a woman with breast cancer can still go shopping, work, dress sexily, bring the children to school, but a man with flu will just stay in bed and lie there all day long. So if they have to work during treatments, help them to get to the office, help them to feel normal, help them to behave normally. Considerations before returning to work after treatment: the long-term side effects of treatment, physical demands and stress of the work, the need for follow-up care, and creating scheduling options that can help workers, even ourselves, transit successfully. Part-time when we first return, flexi time to leave for medical appointments, job sharing, and of course, eventually for those who really needed unpaid medical leave. And with that, I thank you so much for listening in, and I give the podium back to Hui Sing. Over to you. Thank you.
Thank you very much, Dr. C, for such a comprehensive and also, I think, detailed information about breast cancer and also what are the risk factors of the breast cancer. So I hope that everyone has also learned about the risk of especially HER2 positive breast cancer and some other knowledge about the general breast cancer or even ER/PR related as well. So now let's take some questions from the floor and we can take this opportunity to chat with Dr. C. So Dr. C, we have a few questions about um, what are the some of the tests that we can use to diagnose HER2 positive breast cancers?
So basically, this is a standard. We use this. The histology is the first one. It's The jargon is called immunohistochemistry, meaning we take the tissue out, we fix it in wax, we cut it very finely into 1 or 2 millimeters, and then we stain it with a certain color. This stain, which is brown, will look for the HER2 receptor. This is the first step. That's why I mentioned HER2 1 plus, 2 plus, 3 plus. 3 plus means strongly staining. Therefore, that would be called a HER2 overexpressed breast cancer. If it's HER1 plus, we call it a HER2 low. If it's HER2 plus, that means not very intensive, then we may ask for a genetic test on the tumor called a FISH test, which is a fluorescent in situ hybridization, or a ISH test or a DISH test. This will tell us if this tumor is genetically expressing the HER2 gene or the CERB2 gene. So these are the standard of care right now.
Okay, thank you very much, Dr. C. So, next questions would be, just now we actually, I heard from Dr. Sid about for the her two, 1, 2, 3, right? So for the two, usually we will use the fish method, which is a genetic testing. But how about, let's say, on a general basis, would you recommend someone or all the women to go for genetic testing to rule out the potential risk of breast cancer? Like, for
Okay,
example, what the Angelina Jolie did,
yes,
so she
yes.
went for the genetic testing and realized that she is at a high risk. So what is your take or advice, let's say, for all the ladies out there about genetic testing?
So basically, Angelina Jolie's mother died of ovarian cancer. So if there is a family history of ovarian cancer, breast cancer, especially in a what we call a primary relative, one level away, a first degree relative, that increases the risk of breast cancer and ovarian cancer by up to 8 times. But it doesn't mean that they are genetic mutation carriers. 80% of breast cancer within the family are not associated with a genetic mutation. A presence of a genetic mutation would make it perhaps 20 times as high a risk of breast cancer or ovarian cancer. So clearly, it's not everyone. The problem with genetic testing is that there is no guarantee that a person with a genetic mutation will get breast cancer. There's also no guarantee, of course, a person with negative genetic testing won't get breast cancer. So the real chance of a person being or having the Angelina Jolie gene in Singapore is about 2.5%. There are actually other genes that have been found now that are similar to the BRCA, but not the Angelina Jolie BRCA gene mutation. So when we ask everyone to go testing, there are three types of results that can come out. One is a positive or a pathogenic mutation. One is a negative result. One is what we call a variant of unknown significance. Because the technology is so sensitive now, we can pick up a lot of the middle ones. The variant of unknown significance means I can find a genetic mutation, but this has not been associated with a high risk of breast cancer. Imagine the person walking around thinking, I have a genetic mutation and I don't know when I'm going to get breast cancer. We can't live like that. We have patients who really worry every time they get a mammogram or they come and see the doctor, worry sick about what they're going to get. Whereas if I have a negative result, I might think, oh, well, then I'm fine. I don't need to go for mammograms. It allows people into this false sense of security. So at this point in time, we do recommend ladies who are young enough, and by young, we now mean perhaps 50 years below. This is a changing target. It used to be 40, now it's 50, perhaps it will change to 60. And in America, they are encouraging every lady with breast cancer to go for genetic mutation genetic testing. Here in Singapore, we still are not so liberal. We're just a little bit more conservative. We say, yes, a patient who is young, who has breast cancer, can consider speaking to a genetic counselor or a doctor to discuss the possibility and the chances of having a genetic mutation. And if it's high enough, proceed to do the testing. So there is a difference between seeking counseling and then getting the test done. Seeking counseling means I'm not sure if I'm at risk. I'm just going to talk to someone and see if my family history is that of someone who has a high risk. So I give an example. My mother had this, my father had this, my grandfather had this, but that was my father's father, but my father was adopted. And then the uncle from the other side of the family had this other. So basically, we have both sides of the family having unrelated cancers. Like one is lung because he was a smoker, one was nasopharyngeal cancer, one was liver because there was hepatitis B, and along the way there was a breast cancer in a 90-year-old. This is not a Although there are five family members in this history, this is not a familial cancer a diagnosis. Conversely, we then have a lady who has, my auntie, who is my mother's first sister, and the second sister, one had ovarian, one had breast, and my mom had ovarian. Yes, then this is a high chance. High, we mean 20% chance of a BRCA mutation carrier. So this person would be strongly encouraged to seek full counseling, followed by a decision to test or not. Having said that, I have many uh, brothers and as well as sisters. That means two sisters having breast cancer. One is a genetic mutation carrier, and the other one isn't. But they have the same breast cancer. So it isn't so simple. So I would certainly not encourage everybody going out to do now this online or internet available genetic testing. That's what at best we call it genetic entertainment. Yes, it is entertaining. It tells me what lineage it is, whether I've got Genghis Khan blood, whether I've got French blood, whether I'm a smart, whether I have the musical gene. But that's more entertainment. It sometimes can pick up the cancer genes, but most of the time it can't.
Okay, so I think thank you very much, Dr. C. So the summary, I think, from the conversation or the sharing is that do always consult your consultant or your oncologist before you would like to proceed with any genetic test to rule out the potential risk factors.
Yes.
So we have some questions from the floor. So SK Ong asked if I'm 12 years HER2 ER positive survivor, does it mean that I'm safe from breast cancer recurrence?
So if this person has had surgery followed by chemotherapy, we still need to continue follow up. If this person has had chemotherapy before surgery and she experienced a complete response, meaning there's no more cancer cells left, then I would say yes, there's more than 90% chance the cancer is not going to come back. So if that's the case, why do we follow patients and why do they have to be on medication subsequently? We do that in order to monitor that 5 to 6% left behind, that small group, because we never know who is going to be. And as well as to look out for new breast cancer primaries on the other breast, unless a person has had bilateral mastectomies.
Okay, so hope Dr. C has answered SK on questions. So the other we have questions from Bhuvana asking, does the risk of developing breast cancer increase when women get menopause?
So um, the there are two ways of looking at this. First of all, increasing age means a person's ability to naturally detox, naturally reduce inflammation, reduces. Hence, more genetic mistakes are made in the body as we are exposed to carcinogens. Hence, generally, when a person is older, they are at a higher risk of breast cancer. Number two, if a person is postmenopausal, especially if they are obese, they have a much higher chance of getting breast cancer compared to if they were obese premenopausal because of the amount of inflammation in the body. So if I'm menopausal and I permit my weight to suddenly balloon by 2 times or 3 times, meaning I used to be 50 kilos and now I'm 80 or 90 kilos, then that greatly increases the risk. Whereas a person who is younger tends to be slimmer because the natural hormones and the natural ability to burn fat, they are at a slightly lower risk. So yes, to answer that the question, does it happen? Yes, but it is important to know the mechanism behind that so that we can reduce the risk.
So I think based on what Dr. C mentioned, even post-menopausal, it doesn't necessarily confirm higher risk of breast cancer because it may be associated with some other factors, for
Yes,
example, obesity, higher
yes,
inflammation risk to the body.
yes,
Okay, understand. So we have a question. We talk about the genetic testing just now. So how about, let's say we combine these two questions together? If a woman is menopausal, does he or she still have to go for genetic testing, or is still based
yes.
on the discussion with the doctor or the oncologist?
Still based. You're still based because we remember I also mentioned on the first slide this thing called the two hit, right? If without at the risk of offending anybody in the audience, let's say that I'm a 25-year-old, I am sedentary, I never exercise, I love to eat my McDonald's, my KFC, my fast food, my yu zha kueh, my char kway teow. That's my normal staple diet every single day. And let's say that I'm a BMI of 20 to 30, and I'm a genetic mutation carrier, then chances of me getting breast cancer at age of 35 is extremely high. But on the other hand, if I'm the same genetic mutation carrier and I am a very active person, I play tennis every day, I keep my body weight down, I eat primarily plant-based diet, I eat very, very little meat. I eat even fish is maybe 2 or 3 times a week. The rest of the time is mainly whole grains, lots of vegetables, lots of sort of like healthy things like olive oil, like a Mediterranean diet. Then I may actually push the risk of my breast cancer and me getting breast cancer till I'm 65, which means there's a 30-year difference between someone who any old how eats and never exercises versus somebody who eats very carefully and exercises every day. We can actually delay the onset of breast cancer. So we know that only now. In the previous time, we used to just think it's just age alone or it's just a genetic mutation. We now know there is a two hit, which means that if a genetic mutation carrier person can sometimes continue to stave away the risk of breast cancer by being extremely healthy. So, yes, in order to pick up the older person who has kept very, very healthy and suddenly at 70 years old they get breast cancer, yes, we still check. But the reason to check is not so to prevent. The reason to check is because we have targeted therapy that can treat the breast cancer now. So, if we know that a person has a genetic mutation, then we are able to find the good medication for that particular type of cancer. So that's the reason why we check it in everyone now.
Okay, noted. Thank you very much, Dr. C. So we have a few questions talking about cancer relapse, which is recurrence. So the first questions will be, is stage 3C recurrence, the risk is it high for stage 3C breast cancer? And followed by that, when we talk about recurrence of the breast cancer, let's say, would there be any change in terms of the breast cancer type if we have relapsed? For example, initially it was ER, PR positive, for example. And then once I get relapsed, will it turn to, for example, triple negative or triple positive? And will it go straight into stage 4 when relapse happens, or it progresses slowly?
Okay, so basically, let's answer the last question first. Does it progress slowly from stage 3 to stage 4 or stage 1 to stage 4? Stage 4 essentially just means the cancer has gone beyond the primary organ to the other parts of the body. The moment that happens, we call it stage 4. So if I have a patient who presented with a small breast lump of 1 centimeter at the time of diagnosis, we do a scan and we already find a lump in the lung that is proven biopsy positive, we already call it stage 4. So it doesn't go slowly into stage 4. Stage 4 is just a staging. Is to know that perhaps in this patient, surgery isn't the best strategy. Chemotherapy or oral medication is. So that also brings me back to the question about follow up. Do I scan the patient every single year with PET CT, bone scan, chest x ray, every single year without fail? Or do I look for symptoms only? Some of the more aggressive breast cancer, we do try and screen, although there's no evidence to show that by screening, we actually really make a whole lot of difference in the patient's overall survival. But if I only always wait until there are symptoms, patients have shortness of breath, cough, weight loss, we can suddenly find a lot of cancer in the rest of the body Thereby, that's the reason why they are symptomatic with cough, shortness of breath, weight loss, and appetite loss. So, yes, it feels to the patient suddenly I've had stage 4, because once there is a spread outside the organ, it seems to be like that. That's the second question, the last question. The second question is, can the diagnosis change? So one of the slides that I had was in front, I talked about heterogeneity of a tumor, meaning in one tumor that is 2 centimeters, it could have a ER strongly positive cancer. It could also have a ER negative cancer. But when I do the biopsy, I only pick up one part. I don't pick up the whole thing, of course. And if I do surgery, I remove the whole lump. Very often, a patient may see the cancer index 70% ER positive, 20% PR positive. Common sense would tell us the other 30% is negative and the other 80% is PR negative. So when there is a recurrence, this recurrence can occur when it hides in sanctuary sites such as the brain, sometimes in the bone marrow. And the after surgery, when we so-called killed the cancer cells, we kill the majority of the cancer cell. Unfortunately, in that 1 to 2% of that cancer cell that we don't kill, in time to come, they can recur. So the higher the stage, the more likely it is. But let's say that we are the graduating class of 2023. I've had my treatment this year and I belong to this graduating class of 2023. All the breast cancer patients in my class are like me. We had surgery followed by chemo or chemo followed by surgery. Now we are on a follow up for the next 20 years to see who will survive to 20 years without any cancer recurrence. So we move on. Every year, let's say 100 of us. At the end of 1 year, still 100 there. At the end of 2 years, still 100 there. At the end of 3 years, still 100 there. If at the end of 20 years, we have 100 there, means 100% cure rate. So that percentage starts from the graduation. If every year I lose one friend to breast cancer recurrence, it doesn't matter if they continue to live 20 years with me. It doesn't matter if they're alive and well at the end of 20 years, but if they had a recurrence, then the percentage will be 1% chance of recurrence, 99% cure. Assumption is that 99% will go to 20 years. So if every year there is a few number that recurs and recurs and recurs and recurs and recurs, if I'm the only one standing at the end of 20 years, to me, I'm 100% cured. But to the person that recurs, she is 100% recurred because you can only have one. But starting at the cohort, that's the percentage. How many percent risk? So for a stage 3 breast cancer, if after all the treatment is done, we generally quote a 20 to 30% chance of recurrence. Why? Because it depends on whether it's slow growing, fast growing, HER2 overexpressed, not for HER2 overexpressed. If we're only talking about HER2 expressed, then yes, there is a risk. That's why we give the chemotherapy upfront right now. By giving the chemotherapy upfront, we can see if a patient had responded well. If they didn't, we go on to the second line treatment. However, we can definitely change our own risk of recurrence by all the things that I've shared before. Reducing stress, reducing being type A, reducing obsessive compulsive behaviors that drives the cortisol up, reducing obesity, increasing physical exercises, all these reduces inflammation that can make a person go from a very high chance of recurrence to a very low chance of recurrence. And this is not just from the chemotherapy, it's post chemotherapy.
Yeah, thank you, Dr. C. So I hope that Dr. C's
Sorry.
explaining.
One last one.
Yeah.
So when the cancer recurs, can it change? It can change because it can go from ER positive to ER negative because it's the ER negative that get left behind. The ER positive is dead already.
Okay, okay. So I hope that what Dr. C has explained has cleared or given the clarification to the ground. So we have two more questions. So I'm actually compiling the questions and make it into a generic questions for Dr. C. So the first question would like to ask Dr. C, is that it's about the discontinuation of some of the treatment plan. So there are two questions rose by two participants here, two audience. So there's one is by Selena. So she is actually a stage 3C HER2 positive breast cancer survivor. So she was told to do a surgery by the doctor because the tumor was found on the right lymph nodes armpit and also the neck, shoulder, collarbone. However, she refused to do the surgery but undergone all the treatment, which is the chemotherapy and also the radiotherapy. Doctor still suggested her to do the surgery. So would like to check with Dr. C whether this is the, the advice to her, which is continue the monitoring, follow up, or surgery will be the better options for her.
So many patients will think that chemotherapy and radiation replaces surgery, but medications, chemotherapy, radiotherapy cannot replace surgery because it's only after we remove the tumor can we tell whether there's any residual cancer behind. No matter what type of scans we do, we cannot tell if there's a microscopic cancer left behind. As long as there is microscopic residual cancer left behind, there is a chance that this can regrow in time to come. So, when I mentioned neoadjuvant chemotherapy, many patients will light up and say, "Oh, does that mean I don't need to have surgery? Such a good shrinkage, what? All gone already." So, I usually would advise the patient there are a few responses. Number one is clinical response. Now you can feel it, tomorrow you can't. That's called clinical response. If I can see it on the x-rays later, I can't see it on the x-ray, that's called radiological response. But to achieve complete pathological response require us to remove the lymph nodes and the breast tissue, whether it's just the lump or the breast, in order to tell if the microscopic cells are also disappearing. But unless we remove it, a biopsy isn't accurate. Because a biopsy is like asking me to use a pair of chopstick, not a pair, one chopstick, go into a big bowl and try and jab at a fish ball, but I can't see. It's just into a bag, a black bag, with lots of fishball running around. One chopstick. If I'm lucky, I hit the hit the fishball. If I'm not lucky, I don't hit the fishball at all. So in a way, to remove the whole thing means I open up the entire bag and see how many fishballs there are. So to do the surgery, essentially two reasons. Number one is to find out if there is still residual tumor. Number two is to remove the stem cells that are abnormal. Clearly, this breast or this lump is not normal. It undergoes some carcinogenesis. Given enough time, there is a risk of it coming back again. Therefore, surgery is always, or I wouldn't use the word mandatory, but very highly encouraged. Of course, we can never force a patient into doing it, but it's about key of how we explain to the patient and why it must be done. I mean, if I always believe that if we can explain it to a patient properly, common sense would have us understand that it is for the patient's goodness before we recommend the surgery. Sometimes the surgery can be delayed because of other reasons, health reasons. Patients felt that it was bad to do it during the ghost month, or perhaps they felt that this year bad luck to do operation. But there's always eventually a good year for operation.
Understand, understand. So I think always discuss with the oncologist and also make the best
Yeah.
decision out of that. And on top of the surgery, we have another questions from the ground asking, let's say for HER2 positive patient discontinue chemotherapy. So just now we talk about surgery. Now we talk about chemotherapy. So let's say someone diagnosed with HER2 positive discontinue after third cycle of chemotherapy. However, it actually switched to another treatment plan called FESGO. So, what is the prognosis or what is advice from Dr. C?
Yeah, well, I don't think that she has given enough information about why she switched. So FESCO is a targeted therapy, pertuzumab and trastuzumab, which is Herceptin and Perjeta. So pertuzumab and trastuzumab is a combination targeted therapy that's usually given with the chemotherapy. But because FESCO is a subcutaneous injection, it truncates the treatment from infusional treatment of almost 2 hours down to a 15-minute injection. So many doctors would give the Fisco together with the chemotherapy as a maintenance. So a typical picture of a patient who would get Fisco would be PTCH, which is docetaxel, chemo, carboplatin, Perjeta, Herceptin, for the first maybe 4 cycles or so, or 6 cycles, followed by Fisco alone, because there's no infusion anymore. We just use the subcutaneous injection. So I would encourage this lady to go back and find out exactly why she was switched to Fisco. However, if she had advanced breast cancer and she had chemotherapy at the beginning and after 3 cycles they completely disappear, then yes, we can give just Fisco alone as a maintenance therapy. Fisco is a targeted chemotherapy. Yeah.
Ken, thank you very much, Dr. C. So we have a last question here. For HER2 positive on the right breast, does the risk of relapse reduce significantly to almost zero if, let's say, the mastectomy is done on the both breasts? And
Right.
together with after 6 rounds of the neoadjuvant chemotherapy and also
Sure.
surgery.
Sure. So, what she's mentioning is on the contralateral unaffected breast, we call it risk reduction breast surgery. Risk reduction breast surgery means that we remove, if possible, 100% of the breast tissue. Unfortunately, our breast is here, and then in our armpit area, some patients have this thing called the axillary tail, which is like a fish eye, like that. So in a way, that little corner, very, very, very occasionally, in that little corner, there's some breast tissue left behind. And so the chances of getting breast cancer after a risk reduction surgery is about 1 to 2%, which is extremely uncommon. I would say in my 25 years of experience, I only ever see one patient. This patient had breast augmentation. And before she did the breast augmentation, she actually did bilateral breast surgery followed by breast augmentation. And that was her unluckiness, because she actually developed that tiny little lump in the axillary tail. So it's very rare though. So yes, we still encourage patients to do this if they want to prevent breast cancer.
Or rather reduce the risk of breast
Yes.
cancer. Okay, noted.
Yes,
Thank you very
everything
much,
that we
Dr.
do
C.
here is prevention and reduce the risk. Everything that I've talked about in our diet, our exercise doesn't completely eliminate the risk, but it does greatly reduce the risk of breast cancer. And at the same time, this also reduces the risk of ischemic heart disease, colon cancer, renal cancer, stomach cancer, well, many endometrial cancer. So, by adopting, recently there was a very large study that was published that by adopting a good cardiovascular diet, we actually reduce the risk of cancer. And by adopting a good anti-cancer diet, we actually give our heart a break.
Sure, noted. So perhaps let's the audience to have a further study or research about what it means by, for example, cardiovascular diet. So or any like Mediterranean diet, and I think most
Yes,
importantly, it's more on healthy living at the same time not neglecting quality of life. So it's finding a
yes,
balance between your stress and also your healthy lifestyle and physical activity as well.
yes,
Yeah,
yes.
so thank you very much once again for everyone for your questions, and thank you, Dr. C, for all the sharing and answering all the questions tonight. So
Thank
thank you
you.
once again, and hope everyone has benefited from Dr. C's sharing as well. So it is now
Thank
the
you.
time for Dr. C to take a leave. So once again, thank you so much.
Thank you so much. Everybody have a great evening and a great Sunday tomorrow. Thank you and goodbye.
Thank you, Dr. C. So at this point, we would like to have everyone to help us complete a feedback for tonight's sharing. So kindly scan the QR code, or you can take a picture of the screen by using a mobile device, and you may do the QR scanning, or even you can do it now or do it later. So you may also click onto the URL link in the comment sections that will be given to you as well shortly. All right. So our next Facebook Live will be on the 22nd July at 8:30 here, right here on our Facebook platform. And on the day itself, we'll be having Dr. Jonathan Tay, our senior consultant radiation oncologist from Asian Alliance Radiation and Oncology, and he will share with us about sarcoma cancer. So feel free to join in, sit in the session, and probably you can mark on your calendar on 22nd July, which is coming to a month later. So mark your calendar and join us on our Facebook talk on sarcoma cancer. So once again, thank you very much everyone for joining our session tonight, and do like and share our social media pages for all the latest updates on our events such as this Facebook Live event. So thank you once again for spending your evening today, and I hope to see you all in our next session. So take care, stay safe, and good night everyone.